Our work for Metformin was triggered by some observations that actually in the field outside of ophthalmology, that it was found that patients that are diabetic patients that take Metformin, they have similar morbidity and mortality with patients that don't even have diabetes. So this is kind of triggered a discussion that Metformin may actually have some anti-aging properties, and they had less risk for cardiovascular disease, cancer, strokes, and even dementia and Alzheimer's cognitive function. But at that point, when this information came out, there was not much known about age-related macular degeneration, which is the aging disease of the retina. So my team started looking at this question, and as part of the fact that macular degeneration is the aging of the retina, and if indeed Metformin has anti-aging properties and prevents with a healthy aging, it can also affect macular degeneration. And that would be an attractive candidate because of the fact that it's a non-invasive way that can be used in a more preventive intervention before people go to the advanced stage, and then you do more targeted interventions with local therapies. So regarding that, why we want to do GA, so first we kind of approached this question. We started this like almost 7 years ago. There was not much in the literature, and we started to do kind of like answer the basic questions first. Do we see any signal for any AMD? So our first paper that came in JAMA Ophthalmology in 2021, it showed that patients that take Metformin have decreased risk for any AMD diagnosis compared to patients that do not take Metformin. And that was a retrospective case control study looking at over 600,000 patients based on de-identified claim insurance databases that have more information, both for the diagnosis codes, for the CPT codes for eye visits, and also all prescription information. So that was prescription information, is what patients are prescribed. And that was adjusted for age, gender, other comorbidities, smoking, presence of diabetic retinopathy. So after we saw a signal for any AMD, then obviously not all AMD is the same, the different types at different stages, and we start digging into deeper if it's like dry AMD or wet AMD, and that was like 2 follow-up papers showing that Metformin also decreased the odds ratio for new onset of wet AMD and also new onset of dry AMD. And the dry AMD signal was found both for patients with diabetes, but most importantly, was patients without diabetes. So a follow-up study in JAMA Ophthalmology 2023 could look at only patients without diabetes. But Metformin is very commonly prescribed in people pre-diabetes with a different diagnosis code. So these people are not clustered in the diabetes diagnosis coding. And also it's prescribed for people without even diabetes at all, like polycystic ovaries, metabolic syndrome, to affect sometimes even for obesity. So then going forward in the follow-up study of 2023, we focused on patients without diabetes. That would be a more clinical relevant scenario, as the majority of AMD patients are actually not diabetic. And we found that there was decreased risk of AMD and dry AMD in patients without diabetes, and the signal was even stronger, up to 20% compared to patients without with diabetes. And of course, the normal question is geographic atrophy is the holy grail right now in our field, in the sense that it's debilitating, is a major cause of blindness. Until recently, we have no treatments. We still have nothing to prevent it from happening. And even if, despite the new medications, the patients still progress. And the new medications, they have a small efficacy and they have serious side effects. But what about if we have something to delay or even prevent the onset of geographic atrophy? And since we've seen that, we've seen the signal for Metformin be preventive for any other aspects in databases of AMD, then we did another completely new study that could focus on only of new onset of diagnosis of geographic atrophy, looking from 2017 and forward until now, because there was no diagnostic code for geographic atrophy in particular until 2017. So that's why we decided to look at in the Metformin geographic atrophy as a normal sequence of heavy signal for any AMD, new onset wet AMD, dry AMD, both patients with diabetes, but even more stronger signal for patients without diabetes. And then that was the next. And we look both for patients with diabetes and with patients without diabetes for the geographic atrophy study. So, and this study was a retrospective case control study focusing on patients that had a new onset ICD-coded diagnosis with advanced atrophic AMD with geographic atrophy. And they were matched with other patients that have any kind of AMD, dry AMD, without having geographic atrophy. And we excluded patients with wet AMD in this cohort. So either group do not have wet AMD, because sometimes patients with wet AMD also have GA or had GA, and I think it would be a little hard to kind of, just by coding, to kind of like clean them out. So we wanted like a clean study among the group that have dry AMD to see if the signal. And we looked backwards for up to 1 year who was taking metformin or other medications and matched them with these controls. So we had almost 10,000 cases of geographic atrophy, and out of millions of patients, we had matched controls. And then we look back if people that take metformin have decreased odds to develop to be diagnosed with OCD GA diagnosis. And when we look at the whole cohort that had both diabetic and non-diabetic patients, and the cohort that had only the diabetic patients, we found that decreased risk was about 12%. But as I said, in our whole dry AMD cohort, when we look at patients without diabetes, the signal was even stronger. And actually, it's even more clinically relevant to see what happens in the patients without diabetes. And actually, in patients that have no diabetes, the decreased risk for GA was 47%. So like almost 50% less risk to be diagnosed with geographic atrophy, which is like really, really impressive. And this, because I think you take out a lot of variables with the diabetic diagnosis that can affect the risk for geographic atrophy and AMD. And because the signal was so impressive, but obviously was it's a relatively small number of patients, we want to see if it's real. So then we also checked, we matched them 1-to-1, but in the initial study, then we say we matched them 1-to-2 controls and 1-to-3 controls to kind of increase the robustness to see if this signal that was very strong, it was just an outlier, or it was like a true signal. And actually, the signal persisted for 47% decrease of risk for geographic atrophy in patients without diabetes that take metformin. Up to 40%, even we tripled the match to the controls. So I think that's really, really exciting, and it goes along with the previous studies. But it seems that when you look at more specific subtypes and you kind of define your cohorts even more well described and more homogeneously, the signal becomes stronger. And that was very encouraging. And I think definitely we're very excited to see that, especially the non-diabetic cohort for clinical applications. Thank you for this question. And I think that's an excellent question, because I think as a field, it's very important, industry and pharmaceuticals, to trying to identify the best possible drugs that are very specific and targeted once the geographic atrophy has really developed. But right now, there is nothing to stop it from getting there. And we've shown also that once the GA is there, it's very hard to control. Even the agents, it took a lot of years of research, and even the effect that we're seeing is not as impressive. Like we are lucky with the wet AMD. Wet AMD, the anti-VEGF agents are working great, and now we have even a higher duration and durability agents and even stronger agents. But the GA field is very hard, and it's proven to be much harder once you have the GA. So I think there's a huge unmet need to target the disease in the stages before they go to the advanced stages with the vision loss. So we know who is going to get GA. It's going to be people that have intermediate AMD. So, but obviously you cannot inject monthly patients with a drug in their eyes since they're diagnosed with AMD in their 60s, in case they get GA when they're like 70 or 80 or 90. So I think metformin fits very well, and I think it's also like the perfect candidate for a non-invasive strategy to target patients when they're like earlier in the disease stage, when they're early or intermediate, and it's non-invasive, it's safe, it's very affordable. It may help other parts of the body as well, other aspects of aging process, and kind of delay the process until they go to the advanced stages of wet or GA in particular. And maybe once they get GA, they also help to slow down. There was already clinical trial in patients that already had a small clinical trial by Jay Stewart, the UCSF, for patients already have GA, and then start with metformin to see if we can slow down the growth. And it did not reach out statistically significant results, but it was a very small trial, and we know that GA is very heterogeneous. So I'm not surprised even if there was a signal that maybe was not able to be identified because it's a very hard disease to slow down and stop progressing once it's there, especially in the very advanced stages. So I think we need to move the target of intervention sooner, and metformin would be the perfect candidate for that because we can start giving to patients, and it can be also applied in parts of the world that don't have access to very expensive drugs. For example, in Europe, the clopidogrel inhibitors were not approved. And also there's big parts of the world that if they get approved, like Africa or South America or South Asia, there are pockets of rural populations with difficult access to healthcare that it would be very hard to access the drugs. But metformin is already pre-prescribed, is widely available, is very affordable even without a prescription. I don't think we can implement it until we do clinical trial. I mean, so far we have very strong evidence. So I think that as the field, we should find ways to work with funding agencies, foundations, and the National Institute, and also industry to do a clinical trial. It's not going to be a quick clinical trial. It's not going to be a cheap clinical trial in the sense that because now you're talking about prevention and not just you just take a few patients and you inject the medicine and see if it gets better or it slows down worse. It's going to slow down more. It's going to take a lot of patients, and you need to watch them for years. So I think the next goal is to persuade the funding aids and come together as a field to do a trial to really answer this question. Maybe it won't turn out to be true, but so far the signal has been very encouraging, both for preclinical data, animal models that metformin is neuroprotective. My team published in IOVS shortly before the IOVS that metformin prevents wet macular degeneration in animal models through modulating a healthy gut microbiome and a protective microbiome profile. There is evidence from the University of Florida from us group that metformin is neuroprotective for macular degeneration animal models and retinal degeneration animal models. There is a lot of work, in vitro work, that metformin is neuroprotective. And we have a signal from human databases. I actually also published a computational when you go in completely unbiased approach and you plug in all the genes for dry macular degeneration, geographic atrophy, neuroprotection, out of 77,000 compounds in the drug gene analysis, metformin pops out as one of the top candidate compounds. So the evidence is there, but we cannot be sure if it actually works until we do a prospective clinical trial to see if the people that take metformin develop less advanced AMD, either GA or wet AMD or both.